Thank you for being here today, both in person and virtually. We're excited about this event every year. This is our third annual Turner Med Talks, and it continues to grow every year, much to our partnership with THA. And so I want to start by thanking both Lisa Wright and Adrian Nordman for all their help to get us here today. Today we have got a great panel discussion around innovative ways to improve patient throughput and patient outcomes in an emergency department. Our moderator today is our very own John Gromos, Regional Vice President and General Manager of Turner Construction. John, thank you for being here today. I'll turn it over to you.
Yeah, very good. Good morning, everybody who are here with us in person. It is great to actually see and be seen in person, although socially distanced, and certainly good morning and welcome to everyone who is joining us virtually as well. As Paul said, I'm John Gromos, a regional manager for Turner Construction. I'm really honored to be the moderator for this panel. I've had the opportunity to spend some one-on-one time with the three gentlemen here that are part of our panel, and they are very impressive guys, and hopefully I will do a good enough job to pull that out. We'll cover as much ground as we can during the limited time that we have, but let's start off first with just some introductions, and I'll ask each gentlemen to introduce themselves and maybe provide just a little bit of context on their experience with EDs and how their roles are relevant to our discussion today. So, Dr. Hess.
I'm Dr. Eric Hess. I'm the professor and chair at the Department of Emergency Medicine at Vanderbilt University Medical Center. I'm also the chief of service, and we currently provide services at 3 different emergency departments: the University Emergency Department, a new emergency department in Wilson County, as well as the VA and the Veterans Administration Center here in Nashville.
Huddy.
Great. My name is John Huddy. I just go by Huddy, my last name, so the panelists may refer to me as Huddy. That's not honey. I mean, we're close, but we're not that close. So I am president of Huddy Healthcare Solutions. We're an analytics and planning firm that teams with architects, hospitals, healthcare organizations, construction firms, and back in the early 1990s, I started to focus on emergency departments and realized very quickly that as an architect by training, architecture wasn't necessarily always the right answer, that it's operations and flow and communications and technology and all of that. So I developed a specialized ED team that really opened up my eyes, brought on ED physicians and nurses and market and data analysts, and it led us to more than 300 projects, 300 ED projects across the US and around the world, and working in 10 plus different countries, really had the opportunity to see different flows and different ideas. And thank you very much for having me.
Yeah, great. Dr. Woods.
Yes, my name is Dr. Jeffrey Woods, and I'm the Operations Group President with Acadia Healthcare, which is headquartered here in Franklin, Tennessee. Acadia is the largest pure-play provider of behavioral health and substance abuse services in the United States. And as an Operations Group President, I'm responsible for about a third of the operations across the United States for our company, both our acute hospitals, our specialty residential, our residential treatment centers, and substance use disorder programs. I have also the privilege to be involved in a significant number of our joint venture hospitals with large health systems across the United States. And inevitably, the question and the emphasis turns towards ED throughput. In fact, my doctoral dissertation in nursing practice was on ED throughput. So I try to bring that knowledge and those skills to the things that I bring to our company and to our partners.
Great. Well, thank you very much. And before we jump into the questions, just maybe a little bit of housekeeping relative to the program. So I'll moderate a panel discussion for 40 or 45 minutes, and then we certainly look forward to questions and answers. Certainly from those who are with us here live, and there'll be a microphone up front. We'll go through this again, but there will be an opportunity to ask some live questions. And then those who are with us virtually, on your live stream, there should be a red box and a button that you can push to submit any questions that you have. Those will come through to Rachel up front here. She will sort through those and ask questions on your behalf. We may not be able to get to all the questions that come through. We're going to try to maintain an end time a little after 9 o'clock or so with just a little bit of flex. So you don't have to wait until the Q&A period to submit your questions. So as we're going along, especially virtually, please submit those to Rachel through that button and we'll get going. So let's jump into it. I want to start with Huddy first. And that is, you have worked with medical healthcare facilities and organizations across the country and across the world. Just maybe an easy starting question, what are the traditional or typical problems that you see everywhere you go that we need to fix as we go forward?
It is interesting that even, the U.S. isn't necessarily unique in our struggle with emergency departments and flow and patient backup. We see it actually all over the world, even in the U.K., where, we have some jobs and everybody's got nationalized health care. They know exactly who their primary care physician is, and I guess they just don't like him or her, and they continue to come to the emergency department. So I think the struggle that we're seeing is it's not just adding on exam rooms. What we're seeing, though, is older emergency departments that were pretty much built for people to backlog in a waiting room. So I think we're really pushing people to think outside the traditional thoughts of let's triage people and bounce them back to the waiting room. There's new ways of communicating, there's ways of expediting tests, there's some real unique things that we're seeing around the world and across the U.S. And of course, everyone is impacted with rising acuities, older patients. We're tracking the COVID problem, and there's states like Texas that are even beyond where they were pre-COVID. Most states, I'm not sure where Tennessee is, maybe some of you guys know, but most EDs are back to 80, 90% of what they were pre-COVID, and we just see it continuing to increase.
Yeah, and we'll certainly spend some time talking COVID a little bit later on because it has been a game changer, obviously, for what's happening and may be for the foreseeable future. I'd like to get your perspective on how long that may be happening. Dr. Hess, you have been more on the academic medical center side of things, UAB, Mayo, and now at Vanderbilt. So your experience with some of the issues that Huddy talked about, just relative to the problems that you typically see with existing facilities and designs.
Yeah, absolutely. Whenever I think of an emergency department, it's very difficult for me to think of it outside the context of a health system or a hospital. But when you focus on the emergency department itself, depending on how it's been designed, there are a number of classical designs that significantly impact what it's like to deliver care in the emergency department setting. 2 jobs ago when I was in Minnesota, we started off with what's called a ballroom design, which is just a very large room just like this with curtains. And it's very easy to tell when patients are coming and going. And then that was eventually transitioned to a pod design while I was there because we did a renovation. And the pod design is beautiful because you can sit in one spot and just do a 360 and see all the patients you're responsible for at the same time, and you're able to use your senses. What you see, a patient will be rolling in, you're like, that one looks sick, or that one doesn't look too sick. Oh, that's an EMS team, I need to talk to them before they leave, and you know whether or not to interrupt your task. In the current setup that I have, it's really more of a rectangular room in one of our major pods, our B pod, that has 2 different hallways. And the way the EMS flows from the front triage all the way through the back, like you can't see them come in. You may or may not hear the overhead announcement. You're dependent on the electronic health record to give you a clue as to whether or not a patient has arrived. So it can significantly impact what it's like to deliver care in an emergency department setting.
Yeah, and we talked in preparation for this, just there's some challenges on when to open up another pod and from a staffing standpoint too, so maybe share a little thought there.
Absolutely. I think whereas the pod design provides, in my experience, like you know exactly how many entrances and exits there are, you feel like you're in control and you can just understand when people are coming and going. But one of the weaknesses of that design is that when you up staff and down staff, maintaining nursing ratios and figuring out when you can bring people in based on the volume of patients that are typically seen at that time of day is more difficult to determine.
Yeah. And Dr. Woods, your specialty is more on the behavioral health side of things. Just your experiences and maybe some of the trends that are changing very, very quickly from your experience.
Well, I think it's well known to everybody in healthcare and certainly in the acute healthcare system that there is an inadequate access to care for acute behavioral health services, inadequate behavioral health beds across the nation, frankly. And more importantly, there's an inadequate access to lower levels of care because not every patient requires inpatient psychiatric care. And patients are presenting in significant numbers for many, many years now to emergency departments, backing up the workflow for the patients who are coming in for their intended primary medical complaint. And emergency departments are not inherently equipped or capable of managing a more acute psychiatric patient when they encounter them. So in my experience, what I've seen is emergency departments that have, on the one hand, attempted to design and build within their own department a pod, if you will, that would be designed for the behavioral health patient, psychiatrically safe, et cetera. I've seen in most facilities and most emergency departments where there is no sort of set-aside area for the behavioral health patient, and they are mixed in with the general medical population. And as a consequence, it creates all types of workflow issues for nursing and physicians, and then the management of the behavioral health symptoms that can be disruptive to the emergency department and the care of those patients who are there for a more acute medical purpose.
Yeah, so Huddy, I'd like for you, as a consultant, you see facilities across the country and the world, as we mentioned earlier. There are a lot of design professionals here with us live, and I'm sure virtually as well. What counsel or guidance would you give them on maybe challenging the traditional thought? What innovations are you seeing would you want to recommend everyone consider, if they're designing an ED today to be in use in the next year?
Well, I think some of this kind of piggybacks on what Eric was saying in that we do need to consider how we develop zones for care teams to be able to see their patients and access their patients, but still have flexibility between the zones. So instead of isolated physical mods or modules, there needs to be flexibility between all of that. But when we talk about new options in flow, we're working with clients that, the old-fashioned fast track and vertical care and these separate areas of your lower acute, let's send you down the hallway to a smaller exam room or something to be able to treat you. We're doing what some of our clients are calling care initiation, where they're bringing together what was initial kind of a pivot, quick look nurse, triage, fast track, vertical care, all right at the front. Can we treat and treat as many people as we possibly can, and not just the ESI 4s and 5s, but the 3s as well? We're working in Australia, where this is actually a larger area, almost the size of this ballroom, where they have a Cat 3 area, basically ESI Category 3 patients, right up at triage. How much can we do to these patients? What can we get going? How much can we treat them so that we can save our beds in the back, so that we can save them for the sickest patients? So I think reworking that flow with no option to bounce people back to a waiting room. You have to initiate their care. So I think it's got interesting architectural connotations, but I think it's the flow and communication of a patient walks in, what can we do with them as quickly as possible to get their care going? The old physician and triage and some of that you're hearing, I think it's a little offshoot to all of that.
So it certainly, to me, begs the question of flexibility, right? Universal spaces versus specialty spaces. Dr. Hess, you and I talked about that as well. Your thoughts for our design professionals?
Yeah, so in an ideal world, you would want the same technological capability in all of the rooms to provide the maximal degree of flexibility as the patient volumes increase and decrease. in addition to the technological capability, the size of each room has an impact. And so when you work at a high acuity medical center, it's not uncommon. We'll have more than one trauma patient or an acute medically ill patient that would need to have the ability to have a respiratory therapist and a ventilator, the ability to intubate patients and so forth. And so then the size of the room impacts the number of resuscitations that you can have. And even this morning, we're dealing with an interaction with our ophthalmology service because we have a slit lamp and then 3 rooms and really that are adjacent to the slit lamp, which is supposed to be designed for eye patients, but it's actually pretty uncommon. We have 3 eye patients there at the same time, and we'll convert those rooms to be lower acuity rooms for patients who don't need monitoring for that setting. And it's actually more commonly needed for that than it is for the eye room. So this is, I think, a common challenge.
Dr. Woods, as it relates to that from a behavioral side?
So when I think of bottlenecks and impediments to care and the throughput of the psychiatric patient, the areas that I see most frequently are the need for the emergency department staff to be able to rapidly medically clear that individual, identify that there is in fact a primary psychiatric diagnosis or symptoms that require treatment, and then to be able to have appropriate qualified mental health professionals on site or immediately available to disposition those patients to a level of care that's appropriate for them. Because it's not a mystery. I mean, we all know that psychiatric patients are boarding in emergency departments across the nation for hours, days, and in some instances weeks because of lack of access to care. Where I see the biggest impact is really in that medical clearance and ensuring that as the ED physician is making their physical examination of the patient, the tests, laboratory, radiology, any other tests that may be necessary to rule out a co-occurring or an underlying medical complaint that may need higher level medical care, that those things be done efficiently and at the front end. So we've worked in our company and with our partners and with others that we collaborate with, we've worked with them on those workflows, how to be able to identify rapidly the diagnosis for behavioral health, how to medically clear those individuals rapidly, and then how to use appropriate qualified mental health professionals within that environment of care to get those patients properly dispositioned.
Yeah. Huddy?
I'd love to get your input on not necessarily every behavioral health patient needs a lockdown tight room. So when we talk about flexibility and flow, if, as you said, an ED's designed and only has 4, quote, behavioral health lockdown rooms or, intervention rooms, whatever we want to say. But what we're seeing is clients do some unique things, like even day rooms and stuff within emergency departments, people that might just be depressed, sitting with a family member, waiting to be discharged home. So I'd love to hear from you about flexibility. Not every patient's the same.
Not every patient is the same, and the regulations and statutes vary from state to state with respect to how those individuals must be treated within the emergency department environment. And so where you have flexibility, you want to be able to exercise that so that the patient's being treated at the lowest or least intensive level of care necessary for their clinical condition. And so we have projects that I'm involved in currently, in fact with a couple of joint venture partners, where we are building an adjacent facility or center to the emergency department. So when the patient comes in and is triaged by the nursing staff generally, and is determined that there is a primary psychiatric diagnosis, they are otherwise medically stable, that they can be diverted to this assessment center where they'll undergo an intake assessment, make a determination about their level of care need, and then make that disposition from that center, freeing up those emergency room beds, freeing up the emergency room staff from having to attend to that patient who is sort of out of scope for the general medical purpose of the emergency department.
Yeah, Dr. Woods, it seems like there are more cases of behavioral health issues associated with COVID, not associated with COVID. Your thoughts and insights there?
Yeah, we are seeing across our enterprise, and I will tell you, we have a large footprint across the United States. And in 2020, we actually anticipated that we would see a reduction in the volume of patients seeking care for behavioral health services. And what we saw, much to our surprise, was a significant surge of patients seeking behavioral health care. And in addition to that, we were seeing, and are now seeing, a significant number of patients who withheld care, who stood back from care because of the COVID environment, and now they are seeking care with increasingly severe symptoms. And so this has been a challenge for us across the United States as we are trying to find solutions to meet their needs. And I can tell you, a substantial number of our facilities across the United States, and I know the same for our folks that work in the same industry that I do, our hospitals are full. They are busy. And they are busy with individuals who are very sick, both psychiatric illness, but we are also seeing a significant co-occurring instances of COVID-related illnesses. More recently, we're beginning to see patients who are presenting with COVID psychosis, which was something new for us. And it has a whole array of behaviors and manifestations that are different than what we experience with general psychosis. And of course, we are seeing just individuals who are just more psychiatrically distressed because of the lack of social interaction, their ability to engage in normal activities of daily living, and all of these stress and pressures are certainly creating challenges. Now, we're seeing that translate to our partners with emergency departments with just substantially increased numbers of psychiatric patients or patients with psychiatric complaints presenting to those emergency departments, and then those departments having difficulty being able to disposition them.
Yeah, and ED staff, I guess, traditionally not trained to deal with behavioral health issues.
So when I was doing my research for my dissertation, part of any dissertation is you've got to do a literature search. And so I did an extensive literature search. And what I found was a whole body of literature that described the phenomenon of patients boarding in an emergency department and the emergency department staff's lack of qualifications or skill or experience, or sometimes just their comfort level with being able to care for an acutely ill psychiatric patient. And it really challenges the workflow for those individuals who are really there to try to take care of those primary medical complaints and concerns that are presenting. And it can be a very taxing problem on the workforce to be dealing with a cardiac case on the one hand and a psychotic patient on the other.
No doubt. Huddy?
And some of these centers that you talk about adjacent to the emergency department, we've developed some of those with the ability, what might be 12 or 16 rooms, and they can actually break them down to groups of 2, 4, 6, or 8 because of the mix of male-female or adolescent behavioral health versus adults. So again, not every patient's the same, and it's a huge challenge. And I know Dr. Hess, the struggle people have in staffing one-to-one care or one-to-two care, whatever you need, is a real challenge.
Yeah, that's a big challenge, and in order to maintain the safety of each of these patients, it's not uncommon that we have to find a sitter to watch them. And as the behavioral health population increases, there suddenly becomes a need to cohort them in order to conserve the number, our resources for sitters to watch them. And we have a shared model where we have paramedics caring for patients alongside nurses. And our paramedics are fantastic because they're so versatile, but that also enables them to be taken away to another location if we're not available to care for patients. It's not uncommon that they're the sitters just because they're the only ones who can be there. So it's definitely, as we run into those challenges, it significantly increases the difficulty of caring for patients with acute medical and traumatic conditions.
And Dr. Hess, I would just sort of pick up on that a little bit. My job is really in operations, even though I'm a clinical person as well. And when I think about the impact on the cost for healthcare for sitters in an emergency department or sitters on acute medical floors because they can't get the psychiatric patient to an appropriate psychiatric environment, and the cost proposition of an emergency department bed being occupied by a behavioral health patient when there are medical patients who would need that bed, it's a substantial burden on the health system, and it's a substantial burden on the payer system as well. And so finding innovative solutions to improve throughput, whether it is as I mentioned earlier, making sure that those workflows for medical clearance are efficient and that they're timely, that there's some priority, that we don't over-engineer the medical clearance process for behavioral health patient, but by the same token, we don't miss a medical comorbidity or complication that needs to be attended to. Those types of things, or these adjacent facilities or centers where these patients can be taken care of and provided with a behavioral health nurse and a behavioral health tech to monitor and initiate care so that we don't have delays in care for the behavioral health patient. I can tell you, I also sit on the board of directors for the Tennessee Hospital Association, and one of the projects we were involved in here in Tennessee a couple of years ago was an education program for emergency department physicians across the state to educate those physicians on how to administer certain very basic psychiatric medications that will help to reduce the symptoms and intensity of symptoms of the behavioral health patient. We've piloted that now with several hospitals in the state of Tennessee to great success. And so we're seeing that the emergency department physicians are first experiencing a presentation of acute psychiatric disorder, and with these very modest interventions, they're able to stabilize the patient sufficient that the patient can move to a lower level of care and no longer require the emergency department or an adjacent space for care.
So how does telemedicine work into the future to deal with these issues?
Well, so telemedicine is, we as a company, I don't think there's probably any behavioral health company other than those that are specifically in the telemedicine space that really adopted telemedicine wholeheartedly. Within 2 weeks of COVID, we stood up telemedicine across our enterprise, and we were able to reach our patients through virtual consults to emergency departments, virtual consults to the medical floors in the partner hospitals that we work with and with other hospitals. We were even able to take outpatient services where patients would normally come to one of our hospitals or treatment centers and receive partial hospitalization or intensive outpatient services and provide it to them remotely. And we continue to do that today, and provided that the reimbursement models stand up, meaning that the payers will continue to pay post-COVID, we believe that that is the future. So we have really ramped telemedicine in order to be able to provide that coverage in the emergency departments. One of the benefits of that is that when we have a psychiatrist, in most cases a psychiatrist, depending upon the state, who can make that determination about whether the patient is safe to be discharged from the emergency department. And sometimes that involves removing an involuntary detention petition of some form, depending upon the state. That's been very helpful to be able to have that intersection with emergency medicine to get those patients where they need to be.
Any additional thoughts on telemedicine from your guys' perspective?
To me, telemedicine is the wave of the future, and when you combine it with some of our existing services, such as EMS, I know that in Los Angeles they have piloted and tested a pretty attractive model where they outfit ambulances with not only paramedics but also APPs or NPs. And they combined that with telemedicine, and that was their response to the COVID pandemic, because many of these patients would just be concerned about getting the infection. They would meet the patient where they are, and the NP would make a disposition decision at that moment in time. Can the patient go to a community health service if they need just testing, or if it's a behavioral health patient, do they even need to go to the emergency department? And if there's a question that the APP is unable to answer, they can activate telemedicine to an emergency physician at that moment in time. And that substantially decreased the number of low acuity patients being seen in multiple emergency departments. And I see our challenge is aligning the payment models to help us evolve to what is really necessary to meet the needs of our patients in the community. With our current payment models, the hospitals are largely focused on heads and beds, and that's not the wave of the future. But there certainly is there are certainly some bright spots that we can learn from around the country.
Yeah, and it seems like too, and we can talk specifically about Vanderbilt, but just this concept of regional care in dealing with acuities in different locations, that has to factor into as designers are planning and designing, working with healthcare organizations about ED specifically. How does that strategy factor into some of those decisions?
My last job was in Birmingham, and in my mind, the I guess relationship between the different entities, the different health centers, was such that every week, you could, at any moment in time, I could get an Excel file that said, here's the 8 hospitals in the area, and here's exactly the percentage of capacity for each of them. And knowing that if you worked at the tertiary care center, these specialty services that can be offered there. And so the solution's not that difficult. I mean, if they don't have a need for a transplant surgeon or some sort of advanced medical care, then they could be cared for at one of the community hospitals. It wouldn't be very hard to say that one's always at 60%. Let's transport the patient over there. I think it's the barriers and the policies that we have in place and really, I think, frankly, the market competition between our local hospital organizations that prevent us from thinking of it more regionally, which in the end would be what's best for patients, and simultaneously enable the different hospitals to leverage their strengths in ways that would help all those involved.
Yeah. Huddy, thoughts there?
Yeah, architecturally, years ago when we heard telemedicine, it meant we needed to set up a conference room with a screen with telemedicine. But now it's also mobile, that to be able to use it in emergency departments, we're seeing it with the workstation on wheels and all of that, but we are developing physician telemedicine areas within their workspaces, almost like the old dictation, so that you could get some verbal or auditory privacy. The ability to be able to pop up a screen anywhere in a nurse station or physician work area and not disrupt the workers around you, those are the kind of challenging things we're doing. And we worked with some health systems in Europe that the EMS is arriving and popping up a laptop immediately. For telemedicine, the quick interview, again, doing everything possible not to transport people back to an emergency department. So, and I just think with COVID, if anybody was afraid of Zoom meetings 18 months ago, I think we've all gotten beyond our fear of Zoom meetings, and I think more and more patients will be open to that. So.
Yeah. Hey, quick time check. We're at about 8:30 Central Time. Again, if you have any questions, please be thinking of those. Those here will have an opportunity to ask those questions in person. Please submit your questions if you're with us virtually, and Rachel will triage those and pick out great ones to ask the panel. Time has gone by quickly as we anticipated it might. Your guys' thoughts, just where are ED volumes going post-pandemic?
Well, I can tell you that our system is quickly, I think we're pretty close to 100% and breaking 100% really in the last few weeks. And for many months, and I'm speaking primarily of the adult emergency departments, because across the country the pediatric emergency volumes have substantially dropped and they've remained lower than adults seeking emergency care. But our hospitals are full and we're breaking pre-COVID volumes. Last night even. So I think it's raging back, and people are seeking medical care, and they're not as afraid of contracting COVID as they were previously.
Is this a short-term issue, a long-term issue? How does it affect the capacity that designers and facilities need to consider for EDs?
I think it depends on your region. Living in Nashville is a pretty unique experiment with, last I checked, over 80 people a day moving into Nashville, and the sheer need for healthcare is created a significant access issue. Other regions may not have the same situation, in which, in order to, or maybe more competitive environments, such as in the Northeast, in which you really need to reach out and be available to your patient at the point in which they think they might need medical care. And I think we're in a time of our industry in which, the Amazons of the world and so forth, and Apple are simultaneously thinking of ways to compete and get involved in the healthcare arena, and the current healthcare organizations or milieu really needs to take that into account and to force ourselves to be innovative, even though the payment models are making it very difficult for us to be innovative. It's not going to be very long before a patient can look at their Apple Watch and access a physician, and then there's going to be a drone that flies by and provides them the medicines that they need. And we already have a lot of that technology. It hasn't taken over yet. And I think partnering with industry in ways that leverages their current brick and mortar structures with providing patients an opportunity not to drive in and wait, park in a busy parking lot and then wait for a long time to see a patient in a clinic or to see a physician or an APP in a clinic. Those days are in my mind numbered. It's just a matter of how quickly the innovation takes place.
Mm-hmm. Huddy?
Yeah, we have clients now that are designing EDs. We're looking out, we're trying to figure out the market or the service area and all of that. And what we're needing to design is an emergency department that can handle a 20 or 25% surge capacity without putting patients in the hallway. because some of our clients believe, since all of these heart attacks and cancers and all that magically went away over the last year, they think there's going to be a huge bump in the future of really sick people, and then maybe we'll get on a trajectory of where we were historically. So I think there's different ways to design an ED that we don't overbuild the architecture, but we have the ability with maybe some temporary staffing additions or something like that to be able to accommodate more patients in the short term. So it's a mix of that flexibility, having the ability to build universal spaces, any patient in any space, but it doesn't mean you can't define this end will be geriatrics, this will be something else, this will be other different types of patients. There are some specialized patients. There's specialized behavioral health. There's specialized pediatric if you're mixing adult and pediatric. But for the most part, we have to design facilities, operations, staffing, and technology that can handle these flexes and daily, if not seasonal, surges.
Shifting gears a little bit before we get into Q&A, we've talked a lot on the design side to make changes to EDs, existing EDs, renovation. So for our construction folks out here, the challenges and issues that you'd like to share or communicate as you're working on the airplane while it's in flight was the analogy you used, Dr. Hess. Just some thoughts relative to construction.
Yeah, I think the facilities are really going to need to think ahead. And I know that in our current emergency department, we have three different pods, A, B, and the C pod. And given our capacity issues, the C pod is turned into what I call an admissions holding unit. So the A and B pods see all the acute patients, and once a decision is made to admit, the patients are cared for in the C pod. So we have 34 beds over there. So as we renovate and anticipate that we're going to need to use some of that C pod space, so among our hospital leadership, we're now thinking about what is that pop-off valve going to be? Where's another space in the hospital where we can have an admissions holding unit? And so these are definitely important issues to deal with so we can not crash while the renovation's going on.
Huddy.
I think the challenge is, as we said, we don't want isolated modules. We want as much openness and flexibility. But I think where engineers and builders and all of that can really deliver value to healthcare and hospital clients is to help them understand cost, phasing, infrastructure impacts of what's above the ceiling and behind the wall. We always start with, can we have a fully flexible ED, but can we isolate certain sections? And now we're kind of venturing into what COVID has taught us. So many of the clients, we start out saying, can we segment an ED into 4 different air systems and be able to do all of this? And of course, for the last few years, it's always been, well, how much is that? Okay, that's the first thing that gets taken off the board, even though EDs are going to have their own air systems, not necessarily segmented within the ED. I think now what we're learning with COVID is, can we maintain flexibility during business as usual, but do we have the opportunity to set up circulation systems, main street corridors that can maybe feed into different modules that can be open part of the time or can be shut down and segmented? So we're seeing a challenge on multiple levels. Universal rooms, any patient, anywhere, full flexibility, full visibility, with the ability to be able to segment it very rapidly.
Dr. Woods, your thoughts?
I travel across the country and have, even through all of the COVID experience, and many times I would go into emergency departments and they would be almost empty with the exception of those patients that were there for COVID-related illness. And in the last couple of months, I go into emergency departments and I see gurneys in the hallways. Because they are just that heavily impacted as people are coming back out of isolation. When I think about the ED, I think about throughput and I think about the team. Who are the team members and what are their functions? The behavioral health patients are going to continue to present to emergency departments. And we would like to see different solutions, but those are going to be policy level solutions that have to occur for freestanding emergency departments for behavioral health to occur and to occur in a meaningful way. There are some beta tests that are being done now, but they are not looking terribly promising in terms of the ability for those to be successful just from a cost standpoint. So when I think back to the standard emergency department, the acute emergency department, having work areas and workflows and that are representative of the full collection of the team that's going to be necessary to deliver care to the patients. And that includes those qualified mental health professionals, that they have a space, that they have access to the patients, that they are able to perform their functions, whether it's virtual or in person, efficiently.
Yeah, very good. Well, the lights are on. Maybe this is a good point to pause and see what questions we might have. I'll call on somebody here if we don't have anybody step up to the microphone. And I think Wes is on his way up. If you don't mind just introducing yourself and who you're with. Yes, don't touch the microphone. So that I was counseled to remind everybody of that. But
Sure.
Yes, good morning.
Awesome. I'm Wes Crawford. I'm with Vanderbilt. Huddy, I had a question for you. As we talk about throughput, can you talk about some of the innovative solutions that people are doing on the front end to message or communicate? You know, we think about maybe the old time billboard wait times, 5 minutes at this ED. Can you talk about some of the things your clients are doing to help communicate to patients, hey, here's the appropriate place for you to come to receive this appropriate care? It's really difficult to sometimes educate consumers or patients on what they might need. Can you talk about things that they're doing in that space?
Yeah, we have learned a lot from Europe on their nurse call systems. You know, they're not as quickly, what's wrong, go to the ED, you know, and everybody sets up these kind of triage call systems. Well, what we are seeing, though, is more expectations set as soon as they walk into the emergency department. We've done our best to educate, and I hate to say it, I'm going to go back to the UK. The National Health Service is over 60 years old. Everybody knows where they should go for care, and they're still struggling to get them to stay out of the emergency department. I think the great work that a lot of our hospitals in the US have done to get 4s and 5s and lower acuities out. And what we are developing, though, is as part of the discharge process, actually not just pushing them out the door as quickly as we can, but a little bit of an education process as well. Next time this happens to you, here are better resources. Now, the other thing we're doing with information technology is we had a hospital in Texas. You know, you've seen the boards for surgery that your family member's in pre-op or in OR or something like this. There's a hospital in Texas actually where the patient can get a touch screen or can get a remote and actually track their tests. Here's when your rad test was taken. Here's when it's expected to be back. This is when we expect the physician to come in with a discussion and all of that. So they get actually accessing a much smaller version of any kind of medical record. But now they can start to understand the journey and the time. And we've seen 98% satisfaction. It was interesting, this concept of care initiation, where people were coming in and actually 4s and 5s and discharged 3s were being discharged in less than 90 minutes. And the satisfaction was at 13%. And they went back and found out why, and they said a lot of the people were like, did I even see a physician? I mean, I was in and out of here so quickly. And then they found that as long as they communicated with the patient, the next person in the room is going to be a doctor and nurse together. They're going to most likely take some orders. We're going to move you to a more comfortable recliner in our waiting area. We're going to discharge you. We think we're going to get you, then the Disney concept, lie about how long the line is. We think we're going to get you out of here in 2 hours. They got them out in 90 minutes, and it was 98% satisfaction. So I think a lot of that is communication and setting expectations and then beating those expectations.
Thank you.
And actually, Wes, I'm gonna pick up on what Huddy was talking about a little bit from a behavioral health standpoint. Most behavioral health hospitals are subject to CMS requirements to have a dedicated emergency department, which is different than the emergency department you have in an acute general hospital. Not all psychiatric hospitals, but many and most do fall into that definition. And that means that we are required to be capable of providing a medical screening examination for any acute medical condition that might require a higher level of care, but also that, of course, that psychiatric screening. And we encourage our partners in the acute medical side to work with us on educating the patients that if you're having a psychiatric condition, you can go to the psychiatric hospital, and that make them aware of that resource in their community. We try to make them aware through our own channels of advertising and business development and marketing to sort of educate the community about this is where you can come for those services. We also, as a company, I can tell you that we are very committed to seeing that we are practicing our brand of medicine, psychiatry, at the highest level of our license capabilities. So many of our hospitals now are doing things that we would not normally have seen in a behavioral health hospital. So if a patient comes in and is dehydrated, we can, in many of our hospitals, start an IV and hydrate that patient. If they need an antibiotic piggyback, we can initiate that in the hospital and not have these transfers from behavioral health going back into an emergency department and disrupting and congesting the emergency department. So we are taking steps to raise the bar on the expectations of clinical acuity that we can manage within that space. And our hope is that our colleagues in the industry will likewise raise that bar.
That's great. Thank you, guys.
Yeah, very good. Rachel.
Yes, we do have a virtual question. How will the evolution of micro-hospitals and freestanding hospitals impact the approach to standard EDs moving forward?
Who wants to start with that one?
Well, I'm going to start if you don't mind. So micro-hospitals is something that's near and dear to my heart. I haven't done it yet, but it's on my agenda. And this is, of course, in the behavioral health space. There is such disparity in access to care in rural areas in particular. And one of the business model concepts that I'm looking at and our teams are looking at are where we can place micro-hospitals within communities that are very specifically geared towards that demographic, that community demographic. And then to be able to chain those hospitals together, 4 or 5 of these micro-hospitals together with a centralized hub for operations. And then being able to reach people in their communities. If we can reach them in their communities, they're less likely to find themselves in an emergency department.
Any other questions, Rachel? Yep. You're on.
All right, another one from our virtual audience. Is there an ED model currently in use that the panel sees as a progressive framework we might build upon in the future?
Well, I'll jump in. I think I touched on it earlier. There's a very large facility, 80,000 visits going up outside Brisbane, Australia. And this whole concept of this category 3 and what can we actually do at that initial assessment and triage to do as much as possible. And we developed this with them by going through the last few years of records and saying, okay, let's look at all of your category 3s. Who could you have seen, treated, and streeted right at the front door? Now, we all understand that some 3s take a while to really understand what's wrong with them, and they need to be in the back, but they were amazed at the number of patients that they could see at the front door. It ended up being, obviously, all the 4s and 5s, 60% of their 3s treated in what is basically an ignition care area right up front. And then from there, the flexibility for that to actually be flexible with the ED, so that in the middle of the night that might accordion down, and now the ED can run as a fully functioning emergency department, and then at 8, 9, 10 in the morning, as more patients are coming in, start to ramp up this ignition process again. So I think the fully universal care for as many patients as we possibly can. And then if you want to identify areas for geriatrics or other components, but that ability to be able to push ourselves and say, what can we do, one, to educate people away from the ED, but if they do show up, what is everything we can do to keep them comfortable, confidential, all of that? But I hate to say it, treat them and street them as quickly as we can right at the front door with appropriate communications.
So, and I'd like to pick up on that as well, Huddy. When I think about the behavioral health patient coming in through triage, one of the things that creates a bottleneck and a delay for that patient is the post-triage. They go to the back. Now we're going to draw labs, and we're going to do chemistry, and we're going to do all these things. There are technologies that can be leveraged, things like the iStat machine, which most physicians and nurses are familiar with, or similar devices, where even in triage with a single point of care, we could draw chemistry, and we can have chemistry instantly, at least for the purposes of an initial impression of the patient's, their general health. And That information could then inform whether that patient needs to go to the back after a physician or a nurse practitioner has reviewed the chemistry and the other physical health questions that have been asked of the patient, can make a determination about whether that patient really needs to go to the back for further care or whether that patient needs to be diverted for behavioral health services.
Right, and I'd also like to add on that I'm not saying let's extend the triage process to 20 minutes for every patient, but what I am talking about is the ability to be able to have a pivot nurse that right up front, dying, not dying, or behavioral health, do they even need to stay in triage? How quickly can we get them to the back? So I think all of that, it's all that communication and flow process. What needs to be done? Let's get away from this linear process that every patient needs the same exact thing when they come in the door.
And I completely agree with both Huddy as well as Jeff. We recently have revamped our front end process. And if you just look at our total patient population, right now we have a 38% admission rate. That means 62% of those patients go home. If among the level 1s and 2s that either are acute traumatic condition or need acute resuscitation, if you take those out, that's still a substantial number of patients that could be evaluated in a front-end process system. And the challenges we're running into now is like, okay, you don't need acute treatment, you're likely a category level 3. You might be complex, right? And so the physician is going to need to spend at least 15 minutes, maybe sometimes 20 minutes looking through the records and talking to the patient. But just because that's the case doesn't mean there can't be an internal waiting room that they would go to next. And that's the challenge we're running into now, is how do we maximize our front-end process to increase or maximize the number of patients who are category 3 who can be cared for, even if they're complex, if they don't need acute medical treatment, they're not vomiting, they're not in acute pain, they don't need a narcotic. There's a large number of those patients that our current setup is really not conducive to the privacy and really the time that's going to be needed for those patients.
And what if Cat 3 is the lowest acuity patient in the future? If we do get all the 4s and 5s where they should be, then our emergency departments have to be set up for what is now sick patients, but they're going to be our lowest acuities.
We have another question, and while Rachel is queuing that up, you mentioned pharmacy, lab, radiology. Just from the design professional standpoint and just the strategic thought process, what needs to change with those support departments in future ED design?
I think it's been alluded to earlier, we need to maximize the point of care testing. Right up front, we've recently instituted point of care creatinine and point of care urine HCG testing, which has substantially decreased the amount of time we're waiting to obtain imaging from radiology. And simultaneously thinking about the flow of patients, both the higher acuity patients might go through a pod as well as those that might go through a front-end process, and having both of those patients have ready access to the CT scanner and x-rays as part of their normal flow would be important.
And the old-fashioned way of putting radiology, when it is brought into the ED, a lot of times it's at the very back of the ED, so it's easier to get inpatients in and out of it in the middle of the night, when in reality these upfront initial care spaces need imaging involved in it, whether it's the rooms or the portables. But you know, we're putting rad rooms right up front in what is considered triage now. So again, so we can get as many of these tests started as quickly as possible.
And I agree. I think the more we leverage point of care at the front end to answer the question, or to at least initiate the question of do they require validation laboratory or not. Having radiology as close to the front as we can get it, because if you're in many of the health systems that I deal with, radiology is serving the entire hospital. And so the behavioral health patient or the general medical patient, they're in a queue at that point. And that queue can take quite a long time depending upon the severity or the urgency of the need for that procedure or for that test. And so being able to prioritize those and for the best efficiency of the emergency department, I think there's an opportunity there.
Yeah, makes sense. Rachel.
Okay, with the growth of private urgent care centers over the last 5 years, do you foresee large healthcare organizations buying into a lower first cost model, like an urgent care clinic, to reduce first costs, operating costs, and funnel patients into their system to reduce the burden to the hospital ED?
Who wants to start with that one?
Well, I'll jump in quickly and say I have rarely seen success. We've seen urgent cares more as funnels back to the hospital because the communication wasn't there and the education when the patients did arrive. The systems that have been successful drawing patients away through urgent care systems have a strategic plan for communication as to why those facilities are there and really work literally television, radio, any other kind of electronic marketing to make people realize, yes, that's the care location. That's just not our name on a sign to draw you back into the hospital.
Guys?
I think from a hospital administrator's perspective, that would be a really common strategy because emergency care is often more expensive. The flip side, though, is that many of the reasons that patients seek emergency care is because they don't have access to specialty services. And so not only is the emergency department open 24/7, if the patient has a medical condition and hasn't been able to see their rheumatologist or their gastroenterologist, and they feel like it's 6 weeks away till our appointment, there are other issues that need to be resolved, I think, for urgent cares to be maximally effective because they're just not truly addressing many of the patient's needs. People aren't as simple a lot of the times in terms of what the health care they need.
And we are working with both urgent care centers, or payers rather, as it relates to urgent care centers and the health system-owned primary care and multi-specialty outpatient clinics, to be able to operate a collaborative care model so that the primary care physician has the resource of a psychiatrist and a case manager to manage larger volumes of individuals with behavioral health concerns on an outpatient basis to keep them healthier and well longer in the community before they need access to an emergency department or behavioral health hospital.
Yeah, very good. Susanna, we'll let Susanna be our last question, and I'll ask you guys just for parting thoughts and comments after this final question, and then we'll wrap up. So, Susanna.
I was curious, just with the conversation about increased throughput and efficiency in EDs, how much are you seeing the different styles of EDs affect your physician and provider satisfaction as well, the burnout that comes with faster patients, more patients, all of that in consideration?
This whole rapid ignition process that I've been talking about worked with Luis Haro, a common friend of ours. Dr. Haro, we work with him on developing this, and what they found was that this rapid turnaround area, the care team was good for about 4 hours. And then they had to switch people from the front to the back, that really seeing patients jumping from room to room to room to room to room and not having any threes or any sicker patients to deal with. So I think we've got to be very careful about the burden we put on people. And then, of course, when we talk about how the physicians are paid versus, the number of patients they see versus potentially starting tests and then having to hand patients off. So I think all of that it's got to be considered, again, not just architecture, not just flow, but the staffing, the communication, and what are the goals of the health system, what are the goals of the provider, and what are the goals of the staff. And I'll also end with be confident, especially designers, when you're designing an ED. A community-based ED, lower acuity, is very different than an academic trauma center. When we're talking about potentially 30% more space for residents and teaching and all of that, and to just design a standard ED and then try to squeeze teaching into it, that anxiety just rises when there's no place for people to actually work.
I'd say, just to add on to what Huddy had mentioned, in addition to thinking about alternating care teams over a 4-hour period, as for example, think about what are the other pebbles in the shoe that make it difficult to work. And so other models, for example, bringing in scribes to decrease the burden of the electronic health record is an approach. And when you have an efficient process and your physician working in an environment which has tighter processes, the patients are happier. And when the waiting room isn't backing up and you don't have psychotic patients screaming in the waiting room, that is a significant improvement to wellness when your processes are tight enough that occurs very rarely as well.
So I'm going to pick up on Dr. Hess's comment about the anxiety and stress that physicians feel when they have a psychotic patient in the waiting room screaming while they're trying to take care of the complex medical care of the emergency department patients. Part of my training, I'm also a therapist, and I have done a lot of counseling, casual counseling, with physicians who are emergency department physicians who are deeply frustrated with their inability to fully care for that psychiatric patient. And to be able to make an impact for that individual in the emergency department, and the lack of ability to get that patient to the appropriate level of care that they need. And the anxiety that the physicians experience and the nurses experience caring for that patient, where they feel sometimes as though they are not fully equipped to be able to manage that patient, and fearful and anxious about the consequences of an adverse outcome because of those gaps in skill or experience.
Thank you.
Yeah, great question. Thank you. That's a great place to end. Just final comments, nuggets, wisdom, things that you want to reinforce, and then we'll wrap up. Maybe start with you, Dr. Woods.
Yeah, when I think about the consequences of behavioral health care services across our country and access to care, and the burden that it places on the acute health systems, not just the emergency departments, but up onto the medical floors as well. I worry about how we solve for that over time, and I do believe that it is a combination of appropriate new design and engineering for our hospitals, training for our staff, and policy changes that are going to be necessary in order to affect the reimbursement models, as well as the way in which providers can interact with behavioral health patients to ensure that they receive the care they need timely and efficiently.
Yeah, very good. Huddy?
Thanks. We didn't specifically address, quote, safety and security today, but I think everything we talked about impacts safety and security. We get the patients, whether they're behavioral health or other patients, we get them to the right person to be treated the right way as quickly as possible, anxiety's lower. When we have the ability to be able to visually control an emergency department, people act better when they are seen. And when people understand the road they're about to be on, the communication, the care plan, and what you expect during their stay, all of that impacts safety and security. We could do a whole session on, do metal detectors work, and what are the escape paths, and all of that. But I think everything we're talking about, when we talk about capacity and flow and all of that, and for years we talked about patient-centered design, and that's great, and that's what a lot of administrators want to hear. But I can tell you that staff-centered design makes for very happy patients, which is patient-centered design. So when we start to design things that support the staff and the providers and the ancillary departments and all of that, the patients are happier, the family's happier, and it's a safer environment.
There's some wisdom there for sure. Dr. Hess.
I think one of the things that I've struggled with is how we work in our silos. When we run across like the COVID volumes increase, the people that we typically access are those within our own setting. I can't remember the last time we simultaneously talked to an architectural expert and a health systems engineer, in addition to an operations expert, to inform the front-line providers as to how we could address a situation. I think there's untapped expertise that would take us to the next level. And I think more importantly, I think the resolution or the improving or solving these issues it really begs a larger community conversation around what are the true public health needs of our communities, and are we collaborating with our communities? And looking to cities that are positive deviants, or those who have areas of success, and is there a communal access to a behavioral health facility? What kind of conversation would need to happen with the mayor to provide community resources that meet the needs of not only the patients, but then address the challenges of all the hospitals in the region? I think conversations around those lines are going to take us to where we need to go.
Well, very good. The discussion from my perspective has been great. I can't thank you gentlemen enough for sharing your expertise, your time with us, and hopefully we've all learned and benefited from this. So Dr. Woods, thank you so much. Huddy, Dr. Hess, enjoyed this very much. And thank you all for those who came out in person. It is great to see people again, as I mentioned earlier, and for those that are with us virtually, thank you so much for your attention, for the questions that you submitted, and for your support of THA. This type of event doesn't happen just with a snap of a finger. A lot of people have certainly helped pull this together. From the Turner Construction side, Randy Kaiser was integral, I think, with recruiting you gentlemen and helping pull together the agenda. Paul Lawson, thank you for kicking us off this morning. Nathan Hines is here. Thank you so much. And then Rachel, thanks for taking care of the virtual questions for us. And then the staff at THA has been great. This has been very easy to pull together. So Adrian, thank you. I think you're here somewhere. She's outside. Lisa, you're here. Thank you. And Penny as well. So with that, we will wrap up and adjourn. Thanks, everyone. Have a great day and a great rest of the week. Good morning.